Hi, good morning, doctors. Today we are on the 32nd day, and I'm Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. Now on, I'll be doing chapter-wise videos. So we are here at chapter 16, that is dermatology. So let's start reading. It's at page number 559. Page number 560, Skin Assessment. History. Use open questions at the start and become directive when necessary. Clarify, reflect, facilitate, and listen. Ask about the age, gender, influence probability of conditions, because age and gender influence the probability of conditions. Presenting complaint, chronological account when, where, how the problem has started. Ask directly about the skin lesions. What did the initial lesions look like? How have they evolved and extended? Associated symptoms, itching, whether it's associated with itching, sweating, systemic symptoms, aggravating or relieving factors, example sunlight. Past medical history, similar symptoms, uh, similar symptoms in the past, atopy, history of atopy, systemic disease, example rheumatoid arthritis, celiac disease, family history, genetic skin problems, example neurofibromatosis and other family members with similar symptoms, example scabies. Drug history, new drugs including OTC drugs, immunosuppressants, drug allergies, occupational or hobbies. Does the problem improve when away from work or hobbies? Could the problem have been caused by as a result of work or hobbies? Previous treatments tried and result of the treatment. Attitudes and beliefs. How does the patient see the problem? What does he think is wrong? How does he think or she think other people view the situation? What does the patient want you to do about it? Examination. Use a systematic approach to the skin lesions. Distribution. Check the distribution of the lesion, which is mentioned in figure 16.1. Individual lesion morphology. A magnifying hand lens is often helpful in looking at individual lesions. Palpation is also important to determine consistency, depth, and texture. Skin lesions, page 564, we will read in detail. Are the lesions monomorphic? Take one form, example gutted psoriasis, or pleomorphic. Take many forms, example chickenpox. Are there secondary changes on top of the primary lesions like excoriations? How are the lesions grouped locally? Ring shape, linear, Koebner phenomenon. You have to check that. Then check the hair, nails and mucous membranes. Hair problems, nail changes are mentioned in page 574 and 576 respectively. Consider general examination. If an examination of the skin suggests a systemic cause, then you consider general examination. Action. Summarize the history back to the patient and give an opportunity for the patient to fill in any gaps. Draw up a problem list and outline a management plan with the patient. Further investigations and interventions are guided by findings on history or examination. So a good history and examination are essential. Set a review date. So this one is the picture, page 6, figure 16.1, assessing the distribution of skin lesions. So we have to see whether it is localized or generalized. Okay. And if symmetrical, if so, the lesions are peripheral, that is lichen planus, these are peripheral lesions, or central, like pityriasis versicolor. Do the skin lesions involve the flexures? Uh, the flexures, these, eczema, or extensor surfaces, like in psoriasis. So, lesions which involve the flexures are like eczema or extensor surfaces, that is psoriasis. Are the lesions limited to sun exposed areas? We have to see. Are the lesions linear or ring shaped? Page 564. We will see there. Is the distribution dermatomal? Example in shingles. Does the problem affect only one region? Example the axilla, the face, the groin or the foot. So, is it limited lesion? Axilla, face, groin or foot? Assessing the distribution of skin lesions. Second figure, that was in the figure, and the table 16.1. Age, gender, and probability of different skin conditions. Skin conditions that are more common. Males. Seborrheic dermatitis, dermatitis herpetiformis, porphyria cutanea tarda, polyarteritis nodosa, pruritus annai, tinea pedis, cruris, mycosis fungoides, squamous cell carcinoma. These are all common in males, whereas in females, palmoplantar pustulosis, palmoplantar pustulosis, lichen sclerosis, lupus erythematosus, SLE, systemic sclerosis, morphia, rosacea, dermatitis artifacta, venous ulceration, malignant melanoma. Whereas squamous cell carcinoma is more common in males, malignant melanoma is more common in the females, and lupus is more common in the females, lichen sclerosis is more common in the females, dermatitis artifacta, rosacea is more common in the females, venous ulceration is more common in the females. Child, port wine stain. Port wine stain, strawberry nevus, ichthyosis, erythropoietic porphyria, epidermolysis bullosa, atopic eczema, infantile seborrheic dermatitis, urticaria pigmentosa, viral infection, example chickenpox, warts, molluscum contagiosum, head lice and impetigo. These are common in child. Adolescents. Melanocytic nevi, acne is more common in adolescents. Psoriasis, particularly gutted psoriasis, is seen in children. Seborrheic dermatitis, pityriasis rosea, and vitiligo. All of these are seen in children. Early adults. Psoriasis, seborrheic dermatitis, lichen planus, dermatitis herpetiformis, lupus erythematosus, vitiligo, and pityriasis versicolor is seen in young adults. Middle-aged people. Lichen planus, rosacea, pemphigus vulgaris. So pemphigus vulgaris was a new one here. It's seen in middle-aged group. Venous ulceration, malignant melanoma, basal cell carcinoma, fungoides, mycosis fungoides, porphyria cutanea tarda. These are common in middle-aged people, and in old-age people, steatotic eczema. Again, in old age there will be eczema, senile pruritus, bullous pemphigoid. Whereas pemphigus vulgaris is middle-aged, bullous pemphigoid is present in the old-age people. Venous and arterial ulcers, seborrheic warts. Seborrheic warts, solar elastosis and keratosis, Campbell de Morgan spots, basal cell and squamous cell carcinomas, and herpes zoster is more common in the old age. Treatment of skin lesions. The skin conditions are usually treated with topical creams and lotions. Consider the vehicle as we have an active ingredient. In primary care, the choice is usually between creams and ointments. Creams, emulsions of oil and water, well absorbed into the skin, less greasy and easier to apply than ointments. Ointments, greasy preparations suitable for chronic and dry lesions. Alternative includes applications, mouses, foams, gels, lotions, and pastes. Emollients. White soft paraffin, useful for all dry and scaling disorders to soothe, smooth and hydrate the skin. Apply in the direction of the hair growth. So there is one thing that is been specifically mentioned, that when you are applying a moisturizer, apply in the direction of the hair growth, not against it. Effects are short-lived. Advise frequent application even after improvement occurs. Quantities to be prescribed is given in table 16.2. Severity of the condition. Patient preference and site of application guide the choice of the emollient. Some ingredients may cause sensitization. Box 16.1. Suspect if eczematous reaction occurs. Preparations such as aqueous cream and emulsifying ointment can be used as soap substitutes for hand washing in the bath. Addition of emollient bath oil, oleatum or belenium may also be helpful. Aqueous cream should not be used as an emollient. Avoid preparations containing antibacterial dermol unless infection is present or a frequent complication. Use a preparation with added urea, belenum plus or eucerin may improve hydration for scaling conditions in the elderly people. Topical corticosteroids. Used to suppress inflammatory conditions of the skin, eczema, when other measures such as emollients are ineffective, used alone. So use the least potent preparation that is effective. Table 16.3. Apply a thin layer just to the affected areas more than 30 minutes before or after the emollients once daily. Quantities to prescribe. Table 16.2. Creams are suitable for most weeping, moist or weeping lesions, and ointments for dry, lichenified or scaly lesions, or when more occlusive effect is needed. Lotions may be used when minimal application to large or hair-bearing area is needed, or for treatment for exudative lesions. Inclusion of urea or salicylic acid increase the penetration of the corticosteroid. Cautions and contraindications for topical steroids. There are no value in the treatment of urticaria. Topical steroids have no value in the treatment of urticaria, are contraindicated for rosacea and not recommended for acne, may worsen ulcerated or secondarily infected lesions, should not be used indiscriminately for pruritus as they will only benefit if inflammation is causing the itch, should not be used for long term more than 7 to 14 days for children on the face and keep away from the eyes. For perioral inflammatory lesions, use hydrocortisone 1% for less than 7 days or if infected, angular cheilitis, hydrocortisone plus miconazole cream. Potent topical or systemic steroids used to treat patients with psoriasis can result in rebound relapse, development of generalized pustular psoriasis and or local systemic toxicity. So, potent steroids can lead to development of generalized pustulized psoriasis or local or systemic toxicity and cause rebound. Table 16.2. Quantities of emollients and corticosteroids to prescribe. So quantities of emollients and corticosteroids to prescribe. These are face and neck. For the face and neck, if it's an emollient, you have to prescribe 10 to 30 grams. If it's a lotion, you have to prescribe 100 ml. If it's a topical steroid, you need to prescribe 15 to 30 grams. Both hands, 25 to 50 grams emollient and 15 to 30 grams steroid. So for the face, for both the hands or for the scalp, individually you have to prescribe 15 to 30 grams of this steroid. And for both the arms, you have to prescribe 30 to 60 grams. For both the legs, you have to prescribe 100 grams. For the trunk, you have to prescribe 100 grams. For the groins and genitalia, you have to prescribe 15 to 30 grams. Whereas the emollient, you have to prescribe higher quantities. Face and neck 10 to 30, both the hands with 25 to 50, scalp 50 to 100, both the arms 100 to 200, both the legs 100 to 200, trunk 400, groins and genitalia 15 to 25. And whereas in lotion, for the face and neck you have to prescribe 100 ml, both the hands, scalp, arms and legs you have to prescribe only 200 ml, and the trunk you have to prescribe 500 ml, and groins and genitalia you have to prescribe 100 ml. Amounts are for an adult for 2 times per day application for 1 week, and amounts A for an emollient. Amounts are for an adult for 2 times a day application for 1 week, whereas the steroid amounts are for an adult for once a day application for 2 weeks. Because more than 2 weeks the steroid should not be used. So the prescription is for 2 weeks and steroid should be applied only once a day. So once a day application. Very difficult to remember, but try to remember. Box 16.1. Ingredients that may cause skin sensitization. Benzyl alcohol, butylated hydroxyanisole, butylated hydroxyanisole, butylated hydroxytoluene, cytostearyl alcohol including acetyl and stearyl alcohol, chlorocresol, edetic acid, EDTA, ethylene diamine, fragrances, hydroxybenzoates, parabens, imiduria, isopropyl palmitate, methyl chloroisothiazoline MCI, methyl isothiazoline amide, N3-chloroallyl hexaminimum chloride, polysorbates, propylene glycol, sodium metabisulfite, sorbic acid, wool fat or related substances including lanolin. So these are the ingredients present in the emollients which may cause skin sensitization. Topical corticosteroid preparation potencies. So this one is a very important table, doctors. The potency of topical corticosteroids. So mild potent steroids, you have to remember this because it has been asked in various manners in the exam. So mild steroids is hydrocortisone 1% or 2.5%, and also by the brand name. Dioderm, mildisan, see mild and isan. Okay, mildisan, Dioderm, Sinalar 1 in 10. With antimicrobials, canesten, hexi, fusidin, timodin, with crotamidone, Urax, hydrocortisone. So these two are not asked, but hydrocortisone is a mild potent steroid that has been incorporated in our questions many times. Moderate potency steroids, you have to remember beta-metazone valrate 0.025, and that is also called Umovate, Becnovate RD or Umovate. With antimicrobials, Trimovate, with urea alpha-dum, with urea it is alpha-dum. Potent steroids, beta-metazone valrate 0.1%, Becnovate, beta-cap, Elocon, Locolid, Locoid, and Sinalar. With antimicrobials, Oricort, Becnovate C or N, or Fusibet. So Fusibet, which is more commonly used, is a potent steroid. With salicylic acid is diprosalic. Very potent steroids. Dermovate, Nerisone Fort, with antimicrobials, Dermovate N. So here Umovate is clobetasol. Sorry, clobetasone. And Dermovate is clobetasol alcohol. Clobetasol alcohol is very potent, and clobetasone Umovate is moderately potent, and potent is beta-metazone. Elocon is mometasone. One fingertip unit is a unit you prescribe. The unit you ask them to apply. Distance from the tip of the adult index finger to the first crease of steroid cream is sufficient to cover an area 2 times the size of a flat of an adult palm, of course. So that is fingertip unit, and whenever we tell them like one tablet twice a day, like that, when you are telling the patient to apply an ointment, you have to tell one fingertip unit twice a day or once a day, and steroid every time it will be only once a day. 564. Changes in skin color and eruptions. Pallor. Non-specific sign which may be racial, familial, cosmetic. Pathology suggests include anemia, shock, Stokes-Adams attack, vasovagal fainting, myxedema, hypopituitarism, and albinism. All of them can cause pallor. Erythema, page 568. Hypo and hyperpigmentation, page 572. Linear lesions. Consider Cobner's phenomenon. Lesions arise in an area of the injury. Example in the scratches occurs in psoriasis, vitiligo, and lichen planus. So these three conditions are associated with Cobner's phenomenon, wherein the lesions are linear around a scratch or injury. So psoriasis, vitiligo, and lichen planus. Symptomatic dermographism. This is dermographism is whenever you're writing on the skin with the fingers or with anything, you will have some kind of eruptions around the scratches. Symptomatic dermographism. Self-inflicted trauma, dermatitis artifactia. This will also be linear. A reaction to garden plants. Psoralen-induced photodermatitis. Reaction to the garden plants. Psoralen-induced phytodermatitis. Impetigo. That is also linear. Impetigo may spread along the scratch marks. Herpes zoster at the edge of the dermatome. Ring-shaped annular lesions. Whenever you see a ring-shaped lesion, you consider psoriasis. Pityriasis rosea is also ring-shaped. Granuloma annulare. Ring-shaped lesions usually on the dorsum of the hands is granuloma annulare. Discoid eczema, again a ring-shaped ulcerated lesion. Lichen planus, again ring-shaped. Erythema multiforme, target-shaped. Urticaria, wheal, or basal cell carcinoma, Fungal infection like ringworm, again annular lesions. Erythema migrans associated with Lyme disease, again it's like a bullseye lesion. Burns, especially on a child, may be non-accidental injury. Cutaneous T-cell lymphoma is rare, but again it's a ring-shaped lesion. White patches. Consider all causes of patchy hyperpigmentation. Whenever there is white patches, consider all causes of patchy hyperpigmentation like vitiligo. After an inflammation like cryotherapy, eczema, psoriasis or morphia, whenever there is inflammation, there can be hyperpigmentation after the healing phase. Pityriasis alba, white post-inflammatory patch on a child's face, no treatment is needed. It's post-inflammatory patch. Exposure to some chemicals, substituted phenols or hydroquinone can cause white patches. Certain infections, pityriasis versicolor, can cause either hyperpigmentation or hyperpigmentation. In this case, hyperpigmentation. Tuberous sclerosis, the ash leaf patches are hyperpigmented patches. Halo nevus, pale area around a mole. Piebaldism from birth associated with a white forelock. Piebaldism associated with a white forelock means white hair. Okay. Where were he? Huh? Extensive hyperpigmentation. Extensive hyperpigmentation like chloasma, patches of normal skin may appear hyperpigmented. So when there is extensive hyperpigmentation, the normal skin may appear hyperpigmented. White spots. Whenever you have white spots, consider pustules or whiteheads, example due to acne, folliculitis or rosacea. Molluscum contagiosum, white spots with pearl-like appearance. Milia are again small white spots usually on the upper arms or face of the children. Resolve spontaneously. Brown spots. Consider freckles, moles, lentigos like freckles but darker and not affected by sunlight. So whenever you have brown spots, you have to consider whether it could be freckles or moles or lentigos like freckles but darker and not affected by sunlight. Melanoma, capillute spots more than 5 associated with neurofibromatosis, basal cell carcinoma, seborrheic warts, dermatofibroma, systemic disease, Addison's disease will cause hyperpigmentation of the palmar creases. Acanthosis nigricans, hemochromatosis. Hemochromatosis, again there will be generalized hyperpigmentation. Scaling. Silvery scaling on the surface of red patches is psoriasis. Fine scaling accompanied with rash is pityriasis or secondary syphilis. Coarse or scaly skin with no rash, ichthyosis. Localized non-itchy rash. Localized scaling non-itchy is Bowen's disease. Yellow crusting, usually due to staphylococcal infection or impetigo. Yellow crusting, usually due to staphylococcal infection, impetigo. Telangiectasia. Dilated distal venule or arteriole, spider nevus. Causes are congenital. Hereditary hemorrhagic telangiectasias, venous disease of the leg, venous stars, rosacea, facial telangiectasias, excess estrogen or liver disease or CHC, pregnancy, combined hormonal contraceptives or pregnancy can cause telangiectasias, skin atrophy, aging skin, radiation dermatitis, topical steroids can cause telangiectasias. Surface of a basal cell carcinoma, there will be telangiectasias. Spider nevi. Small red lesions barely visible, less than 0.5 centimeters in diameter, in superior vena cava distribution on the arms, the neck, the chest wall. Large arteriole with numerous small vessels radiating from it, giving an appearance of a spider, hence the name. Pressure applied to the central arteriole, example with a pointed object, causes blanching of the whole lesion. So this one is different from something else, I will tell you that. But when it is a spider nevus, when you are applying pressure on the central arteriole, there will be blanching of the whole lesion. More than 2 spider nevus is abnormal. Causes are cirrhosis, most frequently alcoholic, estrogen excess, chronic liver disease or medication, rheumatoid arthritis, rarely, viral hepatitis, transient, pregnancy usually disappear in the first trimester. Blisters, 566, we will read there. Subcutaneous nodules, consider whenever you have subcutaneous nodules, consider whether it is a cyst, a tumor, a furuncle, rheumatoid arthritis, neurofibromas, sarcoid, xanthelasmia, granuloma annulare, or polyarteritis. Purpura. Blue-brown discoloration of the skin due to bleeding within it. Petechiae are small dot-like purpura, while ecchymosis are more extensive. Treat the cause. Idiopathic purpura, pigmented purpuric dermatosis, brownish punctate lesions on the legs, vessel wall defects, vasculitis, paraproteinemias, infection, meningococcal meningitis, septicemia, glandular fever, increased intravascular pressure as in venous disease, clotting defects, abnormal platelet function, thrombocytopenia, anticoagulant therapy, coagulation factor deficiency, defective dermal support, dermal atrophy, example aging, steroids disease, scurvy, vitamin C deficiency. These are all the causes of purpura. Referral of patients with purpura. Admit unwell patients with new purpura or petechiae as an emergency. Refer well children or young adults with unexplained petechiae immediately to be seen on the same day. For well older adults and with unexplained bruising or bleeding or purpura, check the FBC blood film clotting screen and ESR viscosity CRP. So when it is older adults and patient is well, patient doesn't have any other symptoms, and older adults with unexplained bruising, bleeding, purpura, check for a full blood count, blood film, clotting screen, ESR, viscosity and CRP, and then if necessary you refer. Itching and blistering of the skin. Itching, pruritus. In any patient with pruritus or itch, ask, are the skin lesions present? So there is itching. So you have to see whether there are any skin lesions that are present. Skin lesions are present and there is pruritus in the skin lesions. Then search for unexcoriated lesions. Investigations are not usually needed. Exceptions are patch testing for contact dermatitis and skin biopsy for dermatitis herpetiformis. Causes are causes of skin lesions, unexcoriated skin lesions, urticaria, there will be wheals, contact dermatitis and allergy to food and drugs, polymorphic light reaction, skin infestations like scabies, pediculosis, insect bites, psychological causes, excessive scratching or rubbing causes lichenification of the skin, infections, viral example chickenpox or fungal infections, dermatitis herpetiformis, lichen planus, senile atrophy. Skin lesions are absent and there is pruritus. Last differential diagnosis. Look for pallor. So whenever there are no skin lesions and if there is generalized pruritus, no skin lesions, then look for pallor, jaundice, weight loss, lymph node enlargement, abdominal organomegaly. Investigate as necessary. Consider urine analysis, dipstick MSU, FBC, ESR, CRP, serum ferritin levels, LFT, bone profile, including alkaline phosphatase and calcium, urea electrolytes, creatinine, EGFR, HbA1c, TFTs, myeloma screen, and chest X-ray. Consider HIV and hepatitis screen. If still undiagnosed, refer. Causes are causes for pruritus without any skin lesions is hepatic causes, obstructive jaundice or pregnancy, endocrine causes like diabetes, thyrotoxicosis, hypothyroidism, hyperparathyroidism, renal causes like chronic renal failure, hematological causes like polycythemia vera, iron deficiency or leukemia. So if hemoglobin is more like polycythemia vera, also there will be itching. Iron deficiency is there, itching will be there. Leukemia, Hodgkin's disease and myeloma will there be itching. Malignancies, any carcinoma will cause itching. Drug allergies, psychological, observed states and schizophrenia, obsessive states and schizophrenia. Rare causes are HIV, diabetes insipidus and roundworm infestation. Blisters result from separation of the skin layers. The type of blister depends on the level of cleavage of the skin. Subcorneal or intraepidermal blisters rupture easily. Subepidermal blisters are much tougher. Causes are subcorneal, pustular psoriasis. Pustular psoriasis are subcorneal. Bullous impetigo is subcorneal. So they are easily flaccid blisters and easy to rupture. Intraepidermal blisters, eczema, HSV, eczema, herpes simplex virus, varicella zoster. These are intraepidermal blisters. Viruses like chickenpox or shingles, pemphigus and infection. Pemphigus and friction. These are intraepidermal blisters. Subepidermal. Cold or heat injury like burns. Pemphigoid. So pemphigoid are tense blisters. Pemphigoid vulgaris. Pemphigoid is tense blisters. Dermatitis herpetiformis and linear IgA disease. These are subepidermal. Others like insect bite may cause cleavage at any level. Pemphigoid is an autoimmune disorder. Bullous pemphigoid, usually seen in the elderly people. And pemphigus vulgaris, middle-aged people. Bullous pemphigoid, usually elderly, and urticated rash may precede the onset of blistering, large, tense blisters. Because pemphigoid are subepidermal. So the blisters will be tense, not flaccid. Tense blisters arise on red or normal skin on the limbs and trunk and flexures. Oral lesions, 20 to 30% of the patients may be restricted to one site, example, lower leg. Differential diagnosis will be pemphigus vulgaris, dermatitis herpetiformis, linear IgA disease or epidermolysis bullosa acquisita. Epidermolysis bullosa acquisita. Cicatricial pemphigoid mainly affects the mucous membranes in the eyes, mouth. Scarring results in visual loss, refer to ophthalmology. Pemphigoid gestations. Rare but characteristic bullous eruption associated with pregnancy, remits after delivery but often occurs in subsequent pregnancies. Page 791. Management. Check the blood for skin antibodies. So pemphigus is an autoimmune disorder, so you have to check for skin antibodies. Pemphigoid, skin basement membrane antibody is present. 75% of the cases with bullous pemphigoid. Refer to the dermatology for skin biopsy and confirmation of diagnosis. Treatment is usually with oral steroids, prednisolone 30 to 60 milligrams initially daily, reducing as the symptoms improve. Other treatments include antibiotics and nicotinamide, azathioprine or other immunosuppressants. Prognosis for pemphigus. Prognosis for pemphigoid. Self-limiting in 50% cases, steroids are often stopped after 2 years. Whereas pemphigus or pemphigus vulgaris, uncommon autoimmune disorder affecting the skin and mucous membranes. Here it is skin and mucous membrane, there it was only skin. Affects adults, peak incidence is 30 to 70 years. Causes are 90% have detectable circulating autoantibodies to the skin, associated with other autoimmune disorders like myasthenia gravis. Presentation, 50% present with oral lesion. Suspect in anyone presenting with mucocutaneous erosions or blisters. Flaccid superficial blisters then appear sometimes months later over the scalp, face, back, chest and flexures. As the blisters are fragile, they burst early and the condition may present as crusted erosions. Untreated, the condition is progressive. So mucocutaneous erosions and blisters, and as I told you, it is flaccid superficial blisters because these are subcorneal in location. Subcorneal or intraepidermal in location, not subdermal. Management. Check the blood for skin antibodies. Pemphigus skin desmosomal antibodies are present in 80%. Refer to dermatology. Treatment is with high-dose systemic steroids and other immunosuppressive agents. Treatment is continued long term, although occasional remissions may occur. Dermatitis herpetiformis. Males more than females, 2:1. Peak incidence in third and fourth decade consists of itchy vesicular rash on the elbows, the extensor surface of the elbows, the knees, the buttocks, and the scalp, which are often broken by scratching to leave excoriations. Closely related to celiac disease. Up to 20% patients with celiac disease have dermatitis herpetiformis, but classic symptoms of celiac disease are uncommon. Differential diagnoses include scabies, eczema, and linear IgA disease. Management. Management of dermatitis herpetiformis. Check the IgA levels and TTG EMA levels. So, TTG EMA is anti-endomycin antibodies. TTG is tissue transglutaminase antibodies. So check IgA antibody levels and TTG EMA levels. Refer to dermatology for skin biopsy to confirm the diagnosis. Respond well to withdrawal of gluten or a gluten-free diet, although may take up to 1 year. Control in the interim with dapsone or sulfapyridine. Dapsone is for intermittent control of dermatitis herpetiformis. Epidermolysis bullosa, a group of genetically inherited diseases characterized by blistering on minimal trauma. So whenever there is a small trauma, there will be blistering. Range from being mild or trivial to being incompatible with life. The most common form is simple epidermolysis bullosa, which is autosomal dominant. Blistering is caused by friction, is mild and limited to the hands and feet. Patients are advised to avoid trauma. Linear IgA disease, a rare condition of the blisters and articular regions present on the back and extensor surfaces, referred to dermatology. Response to potent topical steroids if mild, erythromycin or dapsone and potent topical steroids. Staphylococcal scalded skin syndrome, we'll see in page 883. Page number 568, erythema. Erythema is redness of the skin usually due to vasodilatation. Erythema is redness of the skin usually due to vasodilatation. It may be localized, example in pregnancy or on the palms, generalized flushing, or take the form of a red rash like drug eruption or viral exanthem. Erythroderma or exfoliative dermatitis. Erythema affecting more than 90% of the skin surface is rare, but systemic effects of skin failure are potentially fatal. And male to female ratio is 2:1. Typical patient is a middle-aged or elderly patient. Patchy erythema becomes universal in less than 48 hours, accompanied by fever, shivering, and malaise. 2 to 6 days later, scaling appears. Skin is hot, red, dry, itchy, thicken and feels tight, and there may be an edema or oozing. Hair and nails may be shed, and admit as an acute medical emergency. Whenever you see a patient of erythroderma, kindly admit as an emergency. Causes: eczema can cause erythroderma, psoriasis, lymphoma, drug eruptions, and other skin diseases. Eczema is the most common cause of erythroderma. Next is psoriasis. Staphylococcus scalded skin syndrome 883. Erysipelas and cellulitis 606. Flushing. Generalized erythema due to vasodilatation, common and usually benign. Tends to affect the face, neck, upper trunk. Cause for physiological, example exertion or heat. Flushing can be due to physiological causes, exertion or heat, emotion, anger, anxiety, embarrassment, food, spices, chilies, alcohol, endocrine causes, menopause, Cushing syndrome, drugs, opioids, tamoxifen, danazol, GnRH analogs, clomiphene, nitrates, and calcium channel blockers. So these all cause opioids, tamoxifen, danazol, GnRH analogs, clomiphene, nitrates, and calcium channel blockers. This cause flushing. Dermatological causes like rosacea can cause flushing. Contact dermatitis. Inflammatory conditions like SLE and dermatomyositis. Infections like slapped cheek syndrome or fifth disease. Cellulitis or erysipelas can cause redness, flushing. Tumors. Pancreatic tumors, medullary thyroid carcinoma, carcinoids, and pheochromocytoma. These are the 4 tumors that may cause flushing. Management. Treat the possible cause. Avoid alcohol or hormone replacement therapy. Embarrassing flushing may be helped with propranolol 40 mg OD or BD or clonidine 50 micrograms BD. If severe and disabling and no response, conservative measures, consider referral to dermatology. Palmar erythema. Generalized reddening of the palms associated with pregnancy, liver disease, and polycythemia. Is palmar erythema. Erythema nodosum. Tender erythematous nodules 1 to 5 centimeters in diameter on the extensor surfaces of the limbs, especially the shins, plus or minus ankle, plus wrist, arthritis, plus fever. Erythema nodosum. And female to male is 3:1, resolves in less than 8 weeks. It is non-scarring. No treatment is needed. Analgesia and mind compression may ease the symptoms of erythema nodosum because these are tender nodules. Association of erythema nodosum. 20% cases are idiopathic with no associations. The rest of them are streptococcal infection. Streptococcal infection, drugs like oral contraceptive pills and sulfonamides, acute sarcoidosis, inflammatory bowel disease like ulcerative colitis or Crohn's disease, malignancies, and tuberculosis. So these are erythematous nodules, tender erythematous nodules on the extensor surfaces, and mostly they are bilateral, seen of patients with erythema nodosum. Erythema multiforme. Erythema multiforme. Immune mediated disease characterized by target lesions on the hands and feet. The causes are idiopathic 50% of the cases, infective causes, streptococcal cause, HSV, herpes simplex virus, most common cause of erythema multiforme. Hepatitis B and mycoplasma. Mycoplasma can also call erythema multiforme like lesions. Drugs, penicillin, sulfonamides and barbiturates. Others, SLE, pregnancy and malignancy. SLE, pregnancy, malignancy can cause erythema multiforme. Presentation. Target lesions are red rings with central pale or purple area on the hands and feet. New lesions appear for 2 to 3 weeks. Frequently oral or conjunctival and genital mucosa is affected. If severe, termed Stevens-Johnson syndrome. So, erythema multiforme is a spectrum of disorders which with the at the end of the disorder, end of the spectrum, there is Stevens-Johnson syndrome on the other end. So targets lesions, red rings with central pale or purple area on the hands and feet. New lesions appear 2 to 3 weeks. Frequently oral, conjunctival and genital mucosa is affected if severe, termed Stevens-Johnson syndrome. Differential diagnosis of erythema multiforme. Toxic erythema, toxic epidermal necrolysis, Sweet's disease, urticaria, and pemphigoid. These are all differentials. Management. Identification and removal of the underlying cause. Mild cases resolve spontaneously and require symptomatic measures only. Admit if extensive involvement is there. So we can look here. There is this target lesions, ring-like lesions, right? Hat-like lesions. Typical target lesions of erythema multiforme. Rosacea, page number 570. Relapsing and remitting chronic inflammatory facial dermatosis characterized by erythema and pustules. Most common in middle-aged 30 to 50 years in fair-skinned people of Northern European descent, females more than males, no cure. There is no cure for rosacea. Cause is unknown, although possible association with face might Demodex follicularum or Helicobacter pylori infection and migraine headaches. So there is associations of rosacea but cause is unknown. Presentation. Earliest symptom is flushing. Erythema, telangiectasia, papules, pustules, lymphedema affect the cheeks, the nose, the forehead, the chin. No comedones are present. Aggravating factors. Sun exposure. Rosacea is aggravated by sun exposure in 61% cases. Emotional stress, hot weather, alcohol. Alcohol aggravates the symptoms of rosacea. Spicy foods, exercise, cold weather or wind, hot baths, hot drinks, cosmetics or skincare products, and topical steroids. These are the aggravating factors. So whether it is hot weather or a cold weather or wind, hot baths, hot drinks, cosmetics, skincare products, spicy food, alcohol, stress and sun exposure. So these are the aggravating factors. Complications. Rhinopharma, bulbous appearance of the nose, eye involvement, blepharitis and dry eye conjunctivitis. Differential diagnosis. Acne, lacks the comedones and older age group, contact dermatitis. SLE, photosensitive eruptions, seborrheic dermatitis. These are all seen on the face and they are differential diagnosis for rosacea. Management of rosacea, avoid triggers like alcohol or sunlight or spicy food, etc. Antibiotics. Repeat treatment is needed over many years with a prolonged course of topical or systemic antibiotics. Topical ivermectin OD for 3 months or topical metronidazole 0.75% gel or cream for 3 months. Limicycline 408 milligrams OD per orally. Rebound may occur if antibiotics are stopped suddenly. Refer to dermatology if rhinopharma occurs, other ocular complications, or failure to respond to treatment in general practice. Livedo reticularis. Marbled pattern cyanosis of the skin. Livedo reticularis, marbled pattern cyanosis of the skin. If not reversible by warming, investigate and treat the cause. Causes are physiological cold, vasculitis, example SLE, and hyperviscosity syndromes. Chilblains. Inflamed and painful purple swelling on the fingers, toes, or ears appear in response to cold. Females more than males. Advise warm housing or clothing, gloves, and woolly socks. In severe cases, oral nifedipine may help with chilblains. So this one is the rosacea, the redness and pustules on the nose, and cheeks and forehead, and rhinophyma. Erythema ab ignae. Reticulate pigmented erythema due to heat-induced damage, commonly in the elderly, especially from sitting in front of the fire or using hot water bottles to elevate the pain. In younger patients may be caused by laptop computers balanced on heights. Explain the cause. Resolve spontaneously. Viral rash. Common, particularly in the children, appears suddenly over hours and is associated with symptoms of underlying viral infection. The rash may take many forms but may be usually widespread, red, maculopapular, or blanches on pressure. In most cases, the underlying virus cannot be identified, but viral infections with characteristic rashes include chickenpox, 629, measles 629, rubella 629, fifth disease 629, Rosella infantum 629, hand, foot, and mouth disease, page 629. Management. In all the cases, no specific treatment is needed for the rash. Treat the underlying viral infection symptomatically. Rash illness in pregnancy, page 790. Lyme's disease. Lyme's disease is caused by Borrelia burgdorferi. Spread is by transmitted by ticks, usually from deer or sheep. Presence with Erythema migrans, chronicus migrans or erythema migrans, 75% of the cases. A red macule or papule over the upper arm, leg, or trunk 7 to 10 days after a tick bite, which expands over days and weeks to form a ring with a central clearing. Diameter can be up to 50 centimeters. Further small lesions then develop elsewhere. Flu-like illness plus arthralgia, lymphadenopathy, and splenomegaly is present in Lyme's disease. Symptoms are typically intermittent and changing. Complications include neurological abnormalities, aseptic meningitis, myocarditis, and arthritis. Management. If the symptoms are present, start antibiotics to confirm the diagnosis with serology. False negative results are common. Treatment is usually with 2 to 3 week course of doxycycline. So, in Lyme disease, the course of doxycycline is 2 to 3 weeks. Take microbiology advice. Treatment is with antibiotics after a tick bite but before the symptoms have arisen is controversial. So after a tick bite, you don't have to necessarily give antibiotic to the patient. Removal of ticks, page 1091. So this is the rash of Erythema migrans, Erythema chronicum migrans. Page number 572, pigmentation disorders. Hyperpigmentation. There's a lack of skin pigmentation may be generalized like albinism, phenylketonuria, and hypopituitarism. Albinism, phenylketonuria, hypopituitarism can cause generalized hyperpigmentation, patchy vitiligo, tuberous sclerosis, ash leaf macules, morphea, pityriasis alba, or after inflammation like post cryotherapy secondary to eczema or psoriasis, infection, pityriasis versicolor, or exposure to chemical substituted phenols or hydroquinone around a mole, halo nevus. Hyperpigmentation. Excess skin pigmentation may be genetic, racial, freckles, neurofibromatosis, Peutz-Jeghers syndrome due to drugs, amiodarone causes blue-gray pigmentation of sun-exposed areas, psoralen, minocycline. Minocycline, blue-black pigmentation in the scars and buccal mucosa, chloroquine, blue-gray pigmentation of the face and arms, and chlorpromazine, gray pigment in the sun-exposed sites, cytotoxics. All of these drugs cause pigmentation. So, drugs that cause hyperpigmentation are amiodarone, blue-gray pigmentation in sun-exposed areas, psoralen, minocycline, blue-black pigmentation in scars and buccal mucosa, chloroquine, blue-gray pigmentation in the face and arms, chlorpromazine, gray pigment in sun-exposed areas, and cytotoxics. Endocrine causes: Addison's disease, Kolasma, Cushing syndrome. Nutritional causes: ingestion of carrots, carotenemia, and malabsorption diseases. Post-inflammatory hyperpigmentation, varicose eczema, lichen planus, systemic sclerosis. Other Other causes of hyperpigmentation: benign nevus, malignant melanoma, chronic renal failure, lemon yellow pigmentation, liver disease, jaundice, acanthosis nigricans. Freckles and lentigens. Freckles. Small light brown macules, typically facial, which darken in the sun. They are common particularly in people with red hair and develop in childhood, require no treatment. Lentigens. Also brown macules but scattered and do not darken in the sun, most common in the elderly and sun-exposed skin. Colasma. Patterned macular symmetrical facial pigmentation usually involving the forehead or the cheeks. Females more than males. Peak age is 20 to 40 years. Genetic predisposition is there. Affects dark skin more than fair skin. Risk factors of colasma are UV radiation, pregnancy usually fades after delivery, taking combined hormonal contraceptives or depot contraceptives may be slow to fade if stopped. Use of cosmetic, perfumes or deodorant, soap, phototoxic reactions. Management. Reassurance is normally all that is needed. Consider stopping the hormonal contraception. Avoid irritating the skin with strong soaps and abrasive cleaners. Vigorous photo protection using sunscreen and hat. 20% azelaic acid cream or 0.05% tretinoin cream may be used but requires application for more than 6 months to have any effect. Camouflage cosmetics or fake tanning products. Specialist treatments: chemical peels, laser resurfacing, and pig, pigmanor, pigmanor cream. Refer to expert advice. So we'll stop here, doctors. Tomorrow we will continue from page number 572 from albinism. Tomorrow we'll continue this topic. That's all for today. Thank you. Have a good day.